patient with Glanzmann who's missing alpha 2b beta 3, but has normal expression of the fibrinogen receptor. Of the von Willebrand factor receptor. Sorry. So has normal 1b9 expression. Does that make sense? So that's normal. That's not normal. It shouldn't be down here. It should be up here. And that's flow cytometry. And this patient has less than 5% expression. Essentially absent expression. And some patients with Glanzmann will have some expression, so their platelets might be over here. They'll have some expression of the receptor, but they don't have normal function. So their platelet function testing looks like the platelets can hold hands, but they don't come and they don't play at the party, but they'll have decreased expression. So that usually those patients will have a flow plot that has the platelets hanging out someplace over here. Does that make sense? Okay. So why does that matter? So in patients, we know that patients with Glanzmann who have some expression of the platelet receptor probably have a little bit lower risk of alloimmunization, of isoimmunization if they're getting platelet transfusion. And so for those patients, I'm not saying that we should be giving platelet transfusions willy-nilly to those patients, but those patients probably have a lower risk of isoimmunization. And we maybe need to be a little bit less worried about the risk of becoming platelet refractory in those patients. And that's what the data would suggest. But flow cytometry is really tough to do, and it's very dependent on which antibodies you use. And so if you don't have a really good flow cytometry lab, you can mistakenly characterize patients as having less than 5% expression, or between 5 and 20% expression, or even having almost normal expression of the receptor if you've just done your flow cytometry wrong. And so in that setting, you might consider molecular testing instead, because the molecular testing really accurately predicts what your expression level is going to be, whereas the flow cytometry is not always as predictive. Unfortunately, neither the flow cytometry nor the molecular testing is really good at predicting what your phenotype is going to be, so how much bleeding you're going to have. Because even within the same family where you have multiple affected family members, you can have very different amounts of bleeding. We think that there are other genes that probably affect how much bleeding you have, and other things that may affect how much bleeding you have that go beyond just the simple genetics of, did you inherit this gene or that gene as well? Okay, so the classical teaching in all hematology schools is that Glanzmann is a little bit like hemophilia, but less severe. And I would ask anybody who has said that to one of their students to please talk to some of our patients with Glanzmann, because I think that many of our patients with Glanzmann today have much more significant bleeding than our hemophilia patients. Many of our hemophilia patients, especially with modern treatments, have very minimal bleeding symptoms and really have excellent quality of life without any significant complications as a result of their hemophilia. And our Glanzmann patients, on the other hand, are left with very few therapies, especially very few prophylactic therapies. And their Glanzmann has a much more significant effect on their life. What we can see in children is bleeding, particularly, we see lots of bruising and petechiae in almost everybody. There's bruising. Bleeding with tooth eruption or exfoliation. So when the teeth come in or when the teeth fall out, we can see bleeding. Usually it's not very severe bleeding in that setting, but certainly we can see more bleeding than is expected, which would be essentially none. Gum bleeding and tonsillar bleeding in kids with Glanzmann. We see nosebleeds And that's a major thing I know that our patients have. And the nosebleeds are a huge problem starting from very young ages. So in any baby that presents to me with a nosebleed, I'm automatically thinking about, does this patient have Glanzmann? And I want somebody to prove to me that they don't, rather than looking necessarily to prove that they do. Because it's that unusual to have an infant with epistaxis. Toddlers, school-age children, teenagers all have nosebleeds, and it's very, very common, and it's not necessarily related to having a platelet disorder. But an infant with a nosebleed is very, very unusual, and really needs a good bleeding disorder workup. And one of the other things that is really important is making sure that everybody in the family and everybody who has contact with that child then knows what to do in the case of a nosebleed. And I'm always surprised at all of the things that patients come to me and say, well, somebody told me to hold the top of my nose or to put ice on my forehead. I get putting ice on your nose or pinching the front of your nose. I get putting ice on the back of your neck because it feels good, but I don't know that it necessarily does very much to stop the nosebleed. And then, of course, heavy menstrual bleeding, which we've talked quite a lot about. And the concern, because that heavy menstrual bleeding can start with the very first period, and the concern, of course, with what are you going to do and how are you going to plan for that first period for that young girl that you have who hasn't yet started having her period. We do occasionally see GI bleeding, so gastrointestinal bleeding, blood in the stool, but not so much in children. That's really more something that we tend to see in older adults, but occasionally we'll see that in children. And then very rarely bleeding in the head, usually associated with trauma. So we tell our children to try to avoid those activities that are associated with a high risk of collision. So what I tell my kids is, don't play any game in which the object of the game is to hurt the other person as much as it is to play the game. So football, ice hockey, boxing are out. And I tell families that means flag football, because if you start your kid playing flag football, those kids go on to play regular football. And so if your child's friends are all playing flag football and they progress up, when they get to be the age to move on to regular football, what are you going to do? Are you going to say, okay, now you can't play football, but all your friends are playing football? And so we talk a lot when the kids are younger about starting activities, because I want you to be active and I want you to do something that keeps you moving. I want you to do something that allows for really good bone and joint health, because that's important. And the way to ensure good bone and joint health is to be active. And so I want you to do something, but I want you to pick a sport or an activity that's going to give you a good social circle and lots of friends to hang out with and a nice peer group to be with, but isn't going to be something that you're going to have to give up if you do end up being really good at it and wanting to be more competitive. So we talk about what are we going to pick from the beginning, so that we don't have to then say no later on. Mostly because I don't have a ton of really great prophylactic treatments. Do you have a question?
No.
No, it's all good.
No.
No worries. All right. So our currently available therapy, platelet transfusion, which we all know and love for Glanzmann, not so much. So we like to use HLA matched platelets if we can get them. If not, leukoreduced platelets, which In the United States, not such a big deal because most of our platelet transfusions in the U.S. are actually leukoreduced. Outside the U.S., not necessarily the standard. So ask for leukoreduced platelets if you're going to get them. If you can get HLA-matched platelets, that's better, but they have to be planned for ahead of time, ideally, because they can be hard to get sometimes, especially now with the platelet shortages that we have. So we try to use alternative therapies as much as possible. And therefore, recombinant 7A. I try to get recombinant 7A ahead of time for my patients. So if I have a patient who's had multiple hospitalizations for nosebleeds, or if I have a patient who has had hospitalizations for mouth bleeds, we get prophylaxis with recombinant 7A at home a couple times a week. We start with 3 times a week, and then we'll wean down if we don't need it as often. And it's a fight with the insurance companies to do that. It usually requires multiple phone calls on wires. But I think there is data to support doing this, and we usually can get it after a bunch of back and forth. But it usually it can take some time to go back and forth, but we can usually get it. And I try to make sure that all of my patients have at least 1 or 2 doses of 7A at home, even if they're not on prophylaxis, because I don't know which emergency room you're necessarily going to go to. And while most ERs have it because they like to use it for trauma patients, I don't necessarily know that they're going to have recombinant 7A available. Antifibrinolytics are a really important part of treatment for pediatric patients, and we use them for nosebleeds, for mouth bleeds. We use them if there's bleeding around tooth eruption. We'll do like a day of tranexamic acid or Amicar. For patients who have not yet started menstruating, I make sure that they have Amicar or tranexamic acid at home. And which one they get depends on insurance. So sometimes insurance also won't approve tranexamic acid for the patient until they actually have heavy menstrual bleeding. But we have a free Amicar program through our hemophilia treatment center, so they can at least have Amicar at home until then. So if they're lucky enough to not have had significant other bleeding, we'll have them have Amicar at home. And I've actually taken care of a couple of patients with Glanzmann who've been referred for bone marrow transplant and have gone to transplant for curative therapy. And I will say that in some of these patients, the transplant has been really successful. I've taken care of one patient where the transplant was initially successful, and then she lost her graft over time and ended up with Glanzmann again, and then had to go to second transplant. So as a young woman, and when she was 18. So I think it's definitely something that is being done in patients with Glanzmann, particularly patients who have significant bleeding symptoms or who have an HLA-matched sibling who's not affected. But it's a conversation that needs to be had about risk-benefit. So thinking about genetic testing and when and why to do genetic testing, one of the reasons to think about genetic testing is if you're going to be thinking about transplant, if you're going to be thinking about other types of therapies, or if you're going to be thinking about other potential curative options in the future. molecular testing will confirm the diagnosis. So you can have flow cytometry that shows that you have decreased expression. You can have platelet function testing that shows that your platelets are consistent with Glanzmann Thrombasthenia. But without the molecular testing, we now know that there are at least a couple of platelet disorders that can look similar to Glanzmann and particularly can have some decreased expression of the receptor and actually are Glanzmann-like and are caused by mutations in genes that are not alpha-2b or beta-3, so integrin alpha-2b or beta-3. There are most of the most common cause of that actually is associated with an immunodeficiency, and so usually the phenotype is not that hard to tell because those patients also have lots and lots of infections and don't just have bleeding symptoms. So the most common reason for that is a mutation in a different gene that is Glanzmann-like, but the phenotype only has some overlap. But I think that as we do more genetic testing, we may find that some of those patients who we think have Glanzmann may actually have mutations that are around that pathway, especially those where we haven't been able to fully define their molecular genetics. But it does provide some information about risk of platelet immunization, because if we find your mutation and we know where your mutation is, that we can predict what your expression level is going to be of the protein on the surface of your platelets. And then we can say, oh, well, you're expected to actually make protein that makes it to the surface. Your platelets are going to have expression of the protein. Your risk of immunization is going to be lower. And therefore, we maybe need to be a little bit less worried about giving you platelet transfusions. And then the last thing is reproductive counseling. So for sure, as far as telling them in the future about risk for their children, and also telling you about risk for your future children, if you're going to have any other children. But like I said, it doesn't necessarily inform risk of bleeding for that patient where we're doing the genetic testing or any other children that might be affected. All right, so Glanzmann was initially described in 1918 by Glanzmann, although there are reports in the literature of a platelet disorder that looks like Glanzmann that actually predate this even. In 1962, they actually identified the platelet defect on platelet function testing, what it looks like. In the 1970s, it was determined that it's the 2B3A complex on platelets that was responsible for Glanzmann thrombasthenia, so the molecule on the outside of the platelets was identified. In 1991, they identified the first genetic defects associated with Glanzmann. In 1994, the first stem cell transplant for Glanzmann. So really long times between things. And in 2017, the first FDA-approved treatment, but only for platelet refractory Glanzmann. And we still don't have an FDA-approved treatment for regular Glanzmann with that platelet refractoriness, right? That's the problem people have had in getting recombinant 7A, is that it's technically only indicated if you're platelet refractory. And how do you define platelet refractory? Mm-hmm. I think that anybody who is potentially at risk for isoimmunization or who has had a severe bleed is platelet refractory, and therefore I have no problem saying to the insurance company, this patient has had problems with platelet transfusion and needs recombinant 7A. If you've been hospitalized and have had a platelet transfusion, or if you've been hospitalized and needed to be treated for more than 24 hours for your Glanzmann, for sure you need recombinant 7A. All right. So how do we keep kids or anybody with Glanzmann healthy? I think the key to preventing platelet bleeding is intervening early, and I think that's the most important thing. Platelets are responsible for what we call primary hemostasis, so they're important in starting that blood clot and getting that blood vessel to start to heal. And if that process doesn't start normally, then it's just much harder to get the bleeding under control. And what the evidence in the literature even shows is that the longer a bleed goes on, the harder that bleed is to control. So if we can get bleeding under control without having to go to the emergency room, then you're less likely to need longer treatment, then it's less likely to go on for longer. I mean, that seems sort of intuitive, but so if I can help you by giving you the tools to control your bleeding at home, you're less likely to need to actually come to the emergency room. You're less likely to have bleeding that goes on for days. And one of the biggest reasons for patients, especially young patients, to have to come to the emergency room with bleeding is because of nosebleeds. And so it's really important to do the things that Dr. Connell really talked about in his talk about epistaxis and management of epistaxis and management of nosebleeds. And to help prevent nosebleeds as much as we can, although not all nosebleeds can be prevented, but if it's dry and it's wintertime, using saline gel, particularly for younger kids, rather than just the saline spray. So I recommend saline gel at nighttime for young kids so that they don't pick their nose while they're sleeping, having them sleep with mittens or gloves. Using a humidifier or a cool mist humidifier at night in the room to try to keep the air humidified. And then, of course, you're not going to be able to prevent every nosebleed. So using a timer to time the nosebleeds, just like Dr. Connell said, and using things like Afrin after 5 minutes. All of my families have nasal cease, bleed cease, or nosebleed QR at home, and we actually do recommend the same thing about having nasal tampons at home, so that you don't have to go to the ER to get packed. And we recommend that they dip those nasal tampons in tranexamic acid or Amicar, whichever one that they have at home, and you put those up the nose. And use a nasal clamp instead of trying to hold the nose, especially if you have a young kid who's running around, because it tends to be more comfortable in trying to get them to hold their nose or sit still. Mm-hmm. All right. The other thing is avoiding high-risk activity. That doesn't necessarily mean putting them in a bubble, which I know is sometimes hard to do, but we do say to avoid contact sports, things like high G-force roller coasters and those high-risk activities, avoiding trampolines and trampoline parks. One of the other things that we tell them to do that's really important is dental hygiene. We've gotten a couple of referrals, particularly from outside, where the kids really they would have gum bleeding every time they brush their teeth. So the parents stopped brushing their teeth because they would have gum bleeding every time they brushed their teeth. So then they got really bad gingivitis and really bad dental caries, and then they needed to have a lot of dental work, and we had to come up with a dental plan in order for them to be able to get that fixed. So the goal is actually to not let that happen, and to really start dental care very early, and make sure. An early visit with adolescent medicine, that, or adolescent OB, or adolescent gynecology rather, before menarche, to put a plan in place for what you're going to do when you have that first period. And for when you're going to come to the emergency room, so that you're not bleeding for days before you come to the emergency room. So if you have if you have menarche and the bleeding is heavy from the onset, and you need to change protection more often than every 2 hours, we say start tranexamic acid. If after one dose of tranexamic acid, you're still bleeding through within 2 hours, we ask you to call. If you have recombinant 7A at home, we say to give a dose of recombinant 7A. And if you don't have 7A at home, we say to go to the emergency room. So we only give it one dose of tranexamic acid for the bleeding to slow down before we say with that first menarche to go to the emergency room to get a dose of 7A. Because I don't want that first period to last for a month and end up in the emergency room and hospitalized for 6 weeks because you've got a hemoglobin of 4 and end up in the intensive care unit. And like I said, I try to make sure that all of my patients have at least 2 doses of 7A at home and have a supply of an antifibrinolytic, either Amicar or tranexamic acid. And I think an important part of taking care of patients with Glanzmann is making sure that we assemble the right team to help take care of everybody. And maybe it's not business, but it's sort of our business to take care of these patients. And it's never just one person taking care of these patients, our patients with Glanzmann. It's a whole team of people taking care of them. And so we have hematology, and within hematology, it actually isn't just me. I have a nurse practitioner, I have a nurse, I have a social worker, and we have a psychologist as well who's dedicated to our platelet disorder patients. And then we have a dentist or dental hygienist, so we need somebody from dental who's closely working with us and who is willing to start seeing our patients as soon as they have teeth, to make sure that the parents are brushing their teeth correctly. And so we really want them to be seen the first time by the time that they're 1, and then have those twice-a-year dental visits. And if there's any evidence of any gingivitis or caries or anything, we want them seen quickly. An adolescent gynecologist who's going to see them before menarche, and then a primary care physician who's also familiar with what to do, and urgent care who knows what to do, or who can get them to an emergency room quickly. And then social work and behavioral health support as well, who can provide all the necessary additional supports for these families, because a diagnosis of Glanzmann affects the patient, but it also affects the entire family. It's not just the child who has that diagnosis of Glanzmann, but it's the parents. There's now a lot more missed days of work. There's a lot more doctor visits. There's a lot more things that have to be taken care of. There are insurance issues. There is this whole world of issues that they never imagined that they need to take care of. So there's behavioral health that needs to be support that needs to be provided for the parents and for the child growing up with a chronic disease. And that's a really important part of taking care of these patients as well. And so I think I am just trying to summarize sort of what we do in our approach to patients, but really I wanted to give you guys the opportunity to ask questions. Unless you're all questioned out and just want to get out of here.
I would want your talk, Michelle. I was a little bit confused when you were describing that factor 7A has to be used for certain conditions, although it sounds like you can give it to people to take home and they can administer it themselves. So that would seem like, is that called an off-label use, or is
Yeah, it's called off-label use. So we use medication. So the benefit of being a pediatrician is that we use medicines off-label in pediatrics all the time, because there are many drugs that are not officially indicated or labeled for pediatric patients. For example, Tylenol is not labeled for children under 2, but how many of you have Tylenol at home and have used it in a child under 2 years of age? So it's technically not FDA indicated for children under 2. And there are other medications that don't have an FDA label for particular things where, because those clinical trials were never done in pediatric patients. Now, the FDA has mandated that drug companies do clinical trials in pediatric patients as well as in adult patients. So all of the new medications that are being developed now, thankfully, pediatric trials are also being done so we can make sure that we learn dosing, pharmacokinetics, in other words, like how you respond to the medicine and all the risks and side effects of those medicines, not by trial and error, but by formal clinical trials with those drugs in pediatric patients. But there are lots of medicines that we use in pediatrics sort of because we've used them for years already that we use off-label because we have used them for a while already and we know sort of how to use them, what dosing regimens to use, and that they're safe. And there's published literature about using the medications that way, even though they probably will never have an FDA label to use them that way because it's very hard for a drug company now to go back and do those clinical trials in the pediatric patient and be able to get that information that way. So they may never be able to get the FDA to actually officially say, this is a way to use that medicine. But we use medicines off-label that way quite a bit, at least for now. The difficulty becomes trying to convince an insurance company that that is an okay thing to do and a safe thing to do. And so we often just need to provide the insurance company evidence that it is an okay thing to do and a safe thing to do. Most often that's by providing papers that show that it's a safe thing to do, expert guidelines, or other things like that that can say, this is how we use this medicine in clinical practice. Does that answer your question?
Yeah. I have a follow-up question on that. So for the Novo 7, from what I understood, it's a fight with insurance no matter what.
Yeah.
But so we have 2 boys with Glanzmann's. One has never been hospitalized for more than a day, but one has had an ICU stay. It's never been brought up as an option. And it sounds like from this conference, there are lots of people that just have it in the kitchen and have access to it. So are you saying only for our son who's had extended hospital days, it would be a fight they could take up? Or is it possible that our doctors could make that argument just because it's a good emergency use at home?
So I think, so 2 things. I think it is an argument that can be made to have for emergency use at home for every patient. I think to be on prophylaxis to try to prevent bleeding is a much more difficult argument to make to get regular treatment. And most of the time when I have to make that argument, it's in a patient who's had multiple hospitalizations or has had an ICU stay. And then I usually can make the argument that they've had severe life-threatening bleeding, and this is the only medication that is available to potentially prevent that type of severe life-threatening bleeding again. And usually those are the kinds of things that can be said to justify that type of a prophylactic regimen. And it doesn't need to be forever. For many patients with Glanzmann, and I think that's been the experience of many patients in the room, the bleeding gets better as you get older. So your epistaxis gets better. And some of that is self-regulation. Some of that is you learn what to do and what not to do. You learn how to take care of a nosebleed on your own at home. You learn how to make sure that you got your nasal allergy symptoms under control. You make sure that you control your environment so you're not in too dry an environment and everything like that. Like, you know how to do the things to make sure that you're not going to have bleeding. So I think that is a large part of how come the bleeding tends to get better as patients get older. But I do, and you don't bump into things as much. You don't run into doors. You don't chase your friends willy-nilly without thinking about where you're going because you're not 6 anymore, right? So I think that's part of the reason that patients have less bleeding. But I don't think they need to be on prophylaxis forever when I write for prophylaxis. So I usually ask for a year at a time.
Thank you.
I have a unrelated question, but first, that was terrific. Thank you for the insight on all your work. We, like my wife said, we have 2 kids. One of our biggest enemies in this journey is mosquitoes. Does that surprise you? And just for everyone who wouldn't understand this, if our guy gets a mosquito bite on the back of his knee, there's frequently he can't walk for 4 to 5 days, right? So he's 6 years old, so that doesn't really go over that well. So I'd be curious to know if in the group if that's happened to anybody, and if you have any we're a little bit lost on what to do. Nobody really has a playbook for how to handle that.
Well, so I think I will say that I have not encountered that before. So I'm not entirely sure what I would do for that. I would have to talk to you and ask you specifically what you're currently doing and get a little more information about how you manage it right now. And then maybe we could talk about what you would do.
That sounds great.
You might be able to do it.
I appreciate that.
Yeah.
So you brought up GI bleeds earlier, and you also gave the data of how, like, within pediatrics, it's about a 10 to 20% chance. That is a small chance as well, but GI bleeds, I'm sure, as you know, can get very, very scary in small children. Could you go over kind of the things for parents to look out for to possibly indicate that there might be something else going on inside that they're not seeing?
Yeah, I mean, so GI bleeding is pretty unusual in children with Glanzmann. It's more common in older patients with Glanzmann. I have taken care of 2 patients with GI bleeding in the setting of Glanzmann. In both cases, there was blood in the stool. And so I think in one patient, he had multiple episodes of GI bleeding in later adolescence. In the second patient, it was a younger girl, like pre-adolescent, who had GI bleeding, also blood in the stool with abdominal pain and then sort of bloody diarrhea. Neither of them very clearly associated with sort of a gastroenteritis infection. Blood in the stool is cathartic, meaning that it makes you go. So it can cause diarrhea. So having blood in your stool with diarrhea doesn't mean it's infectious. It just means that the blood itself is causing the diarrhea. And so I would say that if you have a child, or as an adult, if you have bloody diarrhea, you need to get that checked out. And I would probably go to your I would probably talk to your hematologist and find out if they want you to go to the emergency room or some other method of having that checked out by a gastroenterologist, probably with treatment. In both cases, those children were treated with recombinant 7A and actually octreotide for the older adolescent to get the GI bleeding under control. And I'll say one other really quick thing, and that is earlier somebody said something about blood transfusion, and multiple times iron therapy's been brought up. Hemoglobin plays an important role in keeping you from bleeding. So if you're anemic, you are more likely to bleed. This has been very clearly shown actually in patients with renal disease and liver disease. And so the more anemic you are, the higher the chance that you're going to bleed, because your platelets are pushed out to the side of your blood vessels by the amount of hemoglobin that is present in your blood. So the less hemoglobin you have, the more, it's just physics, the more your platelets are going to be in the middle of your blood vessels. And so the harder it's going to be for them to get out to where they need to be in order to stop the bleeding. So anemia is a significant contributor to bleeding in lots of different disorders, including Glanzmann. So it's really important to treat iron deficiency, treat it aggressively and early, including IV iron if needed, even in young kids before menarche for girls, or if they have other bleeding. Blood transfusion can be associated with isoimmunization. So if you can avoid red cell transfusion, you should use red cell transfusion if you need to, absolutely. But again, there is a small risk of isoimmunization with red cell transfusion as well. So like, if you can avoid red cell transfusion, do that by doing other things first, like iron early, and keeping you from bleeding if you can. So again, the sooner you can treat a bleeding episode, the better.
Mm-hmm.
So when my daughter got her port put in, our hematologist did start trialing for prophylaxis using it. Now, we're from Canada, so the product is called Niastase. But I presume it's similar. And I know that the challenge with that is that the half-life of it is quite brief. So could you explain a bit further, I guess, like in terms of how, giving it 3 times a week, like it's only staying kind of active for 2 hours, how that may actually like prevent a bleed if the bleed wasn't going to happen at that exact moment? Like, I'm just curious because we felt like we were grasping at straws, but it was worth trying. And we did trial it for a bit. She had a lot of bleeds during that time. We were actually just about to retrial it because she spent majority of May and June in hospital and required like 4 iron infusions, 3 blood transfusions, and 2 platelet transfusions. So we're like, we got to try something, but I'm just curious, and I don't know if many people in the room know about it, used as a prophylactic.
Yeah, so I wish I had a really good explanation for the pathophysiology of why it works to give recombinant 7A 3 times a week, but it does. And it's great, and it's worked in a couple of my own patients, and it's worked in the literature. And so I actually can't explain it very well why that would work, because you're absolutely right. The half-life of factor 7, recombinant factor 7A, it's activated. So the half-life is like literally 2 hours, less than that. And so I don't really understand the physiology. It makes 0 sense to me, but it absolutely does seem to work. And so, we'll start with 3 times a week. And we'll go up to daily or down to like once or twice a week, depending on how patients are doing.
Oh, about your hemoglobin, what about isn't there a synthetic oxyglobin or something is that something you could use instead so people wouldn't develop
isoimmunization? Yeah, so that's really used in like in trauma or like for acute volume expansion. It's not really been studied or shown to be efficacious in sort of longer term use. So it's really like a volume expander in the setting of like massive hemorrhage or transfusion kind of setting. But I know that, there are people that are working on other therapies, like a longer acting factor 7 and other types of therapies. And I know, Dr. Wilcox is working on specific gene therapies for Glanzmann, other things like that. We have gene therapies for other monogenic hematologic disorders like thalassemia and sickle cell disease. There's actually an FDA approved gene therapy for beta thalassemia major. So I think we're headed towards someday being able to do those sorts of therapies for Glanzmann as well. Curative therapy is probably on the horizon. It's just all those therapies will also have risks associated with them. So, someday that may be an option. It may not be an option for everybody. So we're still going to need supportive therapies. We're still going to need supportive therapies for while you're going through your curative therapy. So I think, there's a lot of work to still be done.
This is back to the question about how to recognize a pediatric GI bleed, just from experience. Mine was recognized by my school teacher. I had no visible signs of bleeding, but I just fell asleep in class. It was unusual because I was always pale. So making sure that your teachers and other family members are looking for subtle signs.
Yeah.
Because my hemoglobin was real low before we even realized what was going on.
Yeah. Yeah. And in the hematology visits and other things like that, when I see my patients, I check a CBC and iron studies because I want to know if you're becoming iron deficient, which will happen before you become anemic. And I want to know if you're becoming anemic from bleeding that I can't see or that like from nosebleeds that maybe you're not even telling me about or whatever. So, I have one young woman with Glanzmann who she's now a little bit older and she tells me more about her bleeding. But when she was 6 or 7, her answer every single time was, nope, no bleeding. Have you had any bleeding? Nope. Any nosebleeds? Nope. None at all? Not a single one? Nope. Not once. Nope. Any blood on your pillow in the morning? Nope. How about at night when you go to bed? Nope. You sure? Nope. Any bleeding when you brush your teeth? Nope. But her hemoglobin was 9. So she was bleeding somewhere. She just wouldn't tell me about it. Now she tells me about it, but she wouldn't tell me about it at first. Yeah.
How common are joint bleeds in your patients or joint? I know those are hard to diagnose, or even just like joint immobility. So we see a bunch of that.
Yeah. So technically not supposed to have joint bleeds with Glanzmann. But I will say that I think that they're under-recognized because I have had a couple of patients who have complained of intermittent ankle pain or intermittent wrist pain that we send them to the emergency room and they're like, they're fine. And then, but for one patient, when we started prophylaxis, that intermittent ankle pain went away. And so I think we probably, we say there's no joint bleeding, or at least that hemarthrosis is rare. I think it's rare because we probably don't look for it as often as we should. I do think that there's probably more joint bleeding that may be associated, particularly if you have like one specific joint that's always hurting. But what we don't see is the kind of hemophilic arthropathy that like the sort of chronic, really bad synovitis and joint, like damaging joint disease that we saw in patients with hemophilia over time. It's probably because the role of platelets different than the role of coagulation factors in the healing in the joint space. So we don't tend to see the kind of chronic arthritis that develops in patients with hemophilia like we do in patients with Glanzmann, but I do think we do that patients can have recurrent bleeding in a joint, and in those patients there may be some benefit to doing a period of prophylaxis to try to keep that from happening again and protect that joint from having a damage that could occur. Great.